Hi folks, it's Beth Wright, providing you a podcast for Chapter 47 for Unit 1, and this is all about Parkinson's disease, or Parkinsonian, you may have heard it called before. Have your exemplars listed, the anti-Parkinson drug classifications. We have our dopamine or dopaminergic agents, levodopa, carbidopa, and then levodopa, carbidopa together, amantadine, bromocriptine, pramipexole, rasagiline, and the ropinirole, and also the tolcapone. And then we have the combination drug, the levodopa, carbidopa, entacapone. And then we have the anticholinergic agents, atropine and benztropine. So let's talk a little bit first about Parkinson's disease. So what this one is all about is the problem with the neurotransmitters dopamine and acetylcholine. So you know about acetylcholine and what it does. But dopamine is another very important neurotransmitter, and again, there's an imbalance of it. So we have too little dopamine and too much acetylcholine when this talking about Parkinson's disease. And it's considered a degenerative disorder. So when it starts, it starts off slow, and then it continues to progress. And it's a disease of the central nervous system, and it's characterized by resting tremors, meaning that, when a person is just sitting there being still, they're going to have some tremors, and you see that like of the hands. Bradykinesia, rigidity, and postural instability. And manifestations of Parkinson's may occur with other CNS diseases or brain tumors or head injuries, and it may in fact not be Parkinson's, but we may see those characteristics there. Drugs that deplete dopamine stores or block dopamine receptors, including some of our older antipsychotic drugs, are phenothiazides and haloperidol, Respirine, and metoclopramide. Those can produce movements disorders such as secondary Parkinsonism, and it can also involve that extrapyramidal reaction, where you have like the slapping of the lips and unusual movements of the tongue. So the problem in Parkinson's is an imbalance in that dopamine, too little of the dopamine and too much of the acetylcholine. And it allows or doesn't allow the person to regulate their posture and their muscle tone and voluntary movement. So we see a decrease in the inhibitory brain dopamine and a relative increase in that excitatory acetylcholine. Now, let's talk a minute about dopamine. It is classified as a catecholamine, and that serves both as a neurotransmitter and a hormone. Now, catecholamines are a group of sympathomimetic amines, which include dopamine, epinephrine, and norepinephrine. And they play an important role in the body's physiological response to stress. Their release at the sympathetic nerve endings increase the rate and the force of muscle contraction of the heart and increase cardiac output. They constrict peripheral blood vessels. They result in an elevated blood pressure, elevated glucose level, and they increase the lipids by increasing the catabolism of fats. So you get with the catecholamines, they cause that sympathetic nervous system reaction. So when we have an imbalance of that, then we see all of these kinds of manifestations of Parkinson's disease. So let's talk a little bit more about those symptoms. The initial symptoms are the resting tremor that begins in the fingers and the thumb of one hand, and they refer to it as a pill rolling movement, like they have a pill in their hand and they're rolling it. And bradykinesia, which is slow movement, and an inability to move, which is akinesia. Rigid limbs, a shuffling gait, which I'm sure you've heard of that before, a stooped posture, a mask-like face expression, like it's just when you look at their face, it's just like their affect is flat, and a soft-speaking voice. And these are less common symptoms that you see, but nevertheless, they are still symptoms. We see personality changes and depression, loss of appetite, sleep problems, speech impairment, and sexual difficulty. So here's a pictogram for you that shows these things. And the age of onset is usually after 50, and it gives you some additional pictures there and additional characteristics like of the bradykinesia. So you see there decreased blinking of the eyelids, which, blinking protects the eyes, so we have an issue with, injury of eyes that can be potential there. You see the tremors talking about there. It can also occur the diaphragm, the tongue, the lips, and the jaw. Muscle rigidity, which increases resistance to passive movement. You see the shuffling gait, propulsive gait, and there is a familiar incident, and it's more common in men. So let's talk about the drugs used to treat this. So we have drugs that help correct the neurotransmitter imbalance, basically dealing with the dopamine. And we refer to those as dopaminergics or dopamine receptor agonists. We also have the drugs that inhibit metabolism of levodopa. So levodopa is one of our main drugs, our prototype, used to treat Parkinson's disease. And the problem with levodopa is that it breaks down really, really quickly in the peripheral tissue. And so we have the medications, the catechol-O-methyltransferase, or COMT inhibitors, that prevent that breakdown of the levodopa. And then we have the medications that inhibit action of the acetylcholine, which are referred to as anticholinergics. So let's talk about the dopamine receptor agonist first, the levodopa, carbidopa. And we again have to consider levodopa is metabolized in that peripheral tissue. So carbidopa is a medication that's given along with the levodopa to help decrease that metabolism. The levodopa is well absorbed and reaches the serum peak levels around 30 to 90 minutes. However, it takes a little while for this medication to start fully showing its benefit. So we've got to teach the patient that we're not going to see this in a day, 1 or 2 doses. It may take a couple of weeks before this starts working. Absorption can be decreased by delayed gastric emptying, which we see with a lot of time with elderly people. So we've got to keep that in mind, and actually there are medications that are used to improve that gastric emptying. Hyperacidity of gastric secretions can also affect that absorption. And competition with amino acids from protein foods and vitamins, vitamin B6 specifically, can affect the absorption. So we, need to do teaching with respect to that. Now, the indications for use is idiopathic Parkinsonism and secondary Parkinsonism. And you may also see this medication used for restless leg syndrome. If a patient has reduced renal failure, then, if the patient has renal failure or severe hepatic impairment, then the dosage does need to be reduced. At the earliest sign of hepatotoxicity, the drug is withdrawn, and there should not be any reinstatement of it. In your book, it talks about home care, teaching that effects may take a while to see, and also the use of a multidisciplinary team or interdisciplinary team of physical therapy, speech therapy, OT, and dietitians to help manage all of the symptoms that go along and possible side effects that go along. So our adverse effects, the most common ones are headache and anxiety. Your older patients may experience hallucination, dementia, and drowsiness. The most severe adverse effects is depression with suicidal tendency. So you know what we got to watch for there. We got to talk to the patient, ask the questions about that. Dyskinesia is another adverse effect. Now the cardiovascular effects that can occur are ectopic beats, tachycardia, chest pain, palpitations, hypotension, vasoconstriction, dyspnea, bradycardia, and a widened QRS interval on the EKG. It can also cause orthostatic hypotension. This effect is common during that first few weeks, but usually subsides. Also, concurrent administration of non-selective MOA inhibitors used to treat depression and levodopa can result in extreme elevations of the blood pressure or hypertensive crisis. So that means we got to look at those meds that the patient's on to make sure we don't have that drug-drug interaction going on. So for all of these side effects that we're talking about, we've got to think about our assessments that needs to be started or needs to be done on patients for that are getting ready to start this medicine. Anytime we talk about an abnormal EKG, ectopic beats, a widened QRS interval, then obviously we need a baseline EKG before the patient starts that to make sure what are we running normally without that medication. It talks about hypotension and vasoconstriction, orthostatic hypotension. So we need to be checking these things to get a baseline on patients. The mental status, the vital signs. So all of that needs to be, we need to gather data, look beyond the words of what they say, and think, okay, what do I need to do for patients who are starting on this medication? Other side effects, GI, we're going to see possibly anorexia, bruxism, which is grinding of the teeth, and nausea and vomiting. So we got to assess for those adverse effects once a patient does start on them. One of them being orthostatic hypotension. So that is defined as a fall in the systolic blood pressure of 20 millimeters of mercury or more, or a diastolic blood pressure of 10 millimeters or more. And we do that lying, standing, sitting. We just measuring the pressure in a supine position can be misleading because a lot of times patients with orthostatic hypotension can have a supine hypertension. So that's why we want to check in all of those different positions. Contraindications for the dopaminergics are hypersensitivity. Of course, that's always going to be the case. Narrow angle glaucoma, depression, may activate malignant melanoma. So looking at the skin, making sure there's not a history of that, and also noting any kind of, doing their ABCDEs for any kind of moles that the patient may have. Hypertensive crisis, peptic ulcer disease, and any kind of severe cardiovascular, pulmonary, renal, hepatic, or endocrine disorders. Also, now back on that previous slide, we already mentioned the use of MAO inhibitors with dopamine can cause a hypertensive crisis, so they need to be off of that for 14 days prior to starting the levodopa. Also, there's some drug-drug interactions that can occur, specifically like with your tricyclic antidepressants. They can experience postural hypotension. Anesthesia can cause dysrhythmias when given with levodopa. So again, we got to look at the meds that the patient's on, and look at that medical history and be sure to assess the skin. We need to assess vital signs and be sure to assess lab work as well. Okay, administering on time for therapeutic effects is going to be really important with this medicine, and also with foods of a low protein, with a meal of a low protein. So do with food or following a meal. Also, no iron or multivitamins or B6 given with it as well. Also, the patient needs to be hydrated really well with this as always, and if it's not contraindicated, that's going to be important as well. There is a sustained release, so we got to be sure to teach the patient not to crush those. Again, avoid the iron or multivitamins. For teaching, that's on page 868, so be sure to read about that. Another thing that you're going to see, not necessarily with this drug, it doesn't mention it, but it can happen with this drug. But any drug used to treat Parkinsonism, you will read about on and off time. And what this is talking about is the on time is when the drug is working. The off time is a period when the medication is not adequately controlling the patient's symptoms. So we need to be sure to teach the patient about monitoring for signs like that, and they need to talk to their physician about that because they, may need an additional medicine added or dosage adjustments done for that. Okay, here are our other drugs in this class. Amantadine, that is actually an antiviral medicine, but it's also used for the Parkinsonism. Its adverse effects can cause dizziness, lightheadedness, and insomnia. And we need to instruct the patient to report any kind of swelling of the fingers or ankles, and any difficulty walking, any urinary retention, tremors, slurred speech, or thoughts of suicide. And it is important not to discontinue this drug abruptly when and if it might be discontinued. Bromocriptine is a ergot derivative, and so with that you got to be mindful of myocardial issues because these medicines can constrict coronary arteries and narrow blood vessels. It's also important, to monitor pulmonary and peritoneal areas because it can cause fibrosis of those areas. Pramipexole is another drug used for this, and most of that drug is excreted unchanged in the urine. So renal failure may cause a higher than usual plasma level and possible toxicity of the drug. So we got to watch about the renal status of the patient for that medicine. Ropinirole, that medicine is an irreversible MAO inhibitor, and it is indicated for the initial treatment of idiopathic Parkinsonism and as an adjunct for with levodopa to help reduce the off time. With this particular, let's see. Let's see now. The ropinirole, it is metabolized by the cytochrome P450 enzyme in the liver, and so we got to watch about any drugs that are competing for that, because a lot of drugs use that cytochrome P450 enzyme to help with metabolizing the specific drug. So hepatic failure may decrease the metabolism and allow for drug accumulation of too much or toxicity. The rasagiline drug, that's the one that is an irreversible MAO inhibitor, and it is used for the idiopathic Parkinsonism and as an adjunct to levodopa to reduce off time. With this particular drug, you got to avoid the tyramine containing foods because it will cause problems with the medication, such as a hypertensive crisis. And so examples of this are strong aged cheeses, any cured meats, smoked or processed meats, pickled or fermented foods, specific sauces such as soy, shrimp sauce, teriyaki, soybean, snow peas, broad beans, dried or overripe foods, meat tenderizers, any kind of yeast extract spreads, or sourdough bread or brewer's yeast, alcoholic beverages such as beer, especially tap or homebrewed beers, red wines, sherries, and liqueurs, and improperly stored foods or spoiled foods are also definitely need to be avoided. Now, the thing about this particular drug is it has a potential to increase serotonin transmission, and so if it's given with other drugs that enhance the stimulation of the serotonin receptors, it can cause serotonin syndrome, which is a potential fatal CNS toxicity. And one characteristic of that is a really high fever, and death can occur with that. So it should be discontinued at least 14 days before beginning treatment with most antidepressants or other MAO inhibitors. Okay, your catechol-O-methyltransferase or COMT inhibitors. That one is, again, that plays a role in keeping the dopamine from being metabolized, and so that's why we want to have that. So the talcopone is the drug here, and it increases that dopamine in the brain and relieves symptoms. Renal impaired and hepatic impaired have to be cautious there. This is administered only in conjunction with levodopa and carbidopa, and if given, there has to be a reduction in the levodopa dose. If a client does not show benefits within 3 weeks of starting the medicine, then it's slowly tapered off. The patients with moderate to severe hepatic impairment should not take talcopone at doses exceeding 100 milligrams 3 times a day. There is a black box warning with this medication, and that it can cause potential fatal acute filament liver failure or acute renal failure or liver failure. So we got to monitor those liver function tests before therapy begins and every 2 weeks afterwards. The most severe adverse effects is the acute renal failure, and there are CNS adverse effects as well, and that can be disorientation, hallucination, psychosis, dizziness, and orthostatic hypotension can occur as well. Contraindications always will include hypersensitivity to the drug. Other contraindications are liver disease, non-traumatic rhabdomyolysis, hyperprexia, and confusion. Caution is warranted with anybody with hypertension, hypotension, and renal impairment. And also remember, no MAO inhibitors. Nursing administration, we must take with the levodopa and decrease that dose of levodopa. Monitor for improvement, and if it doesn't work, we're going to stop it, but we're going to taper off over a 2-week period. Teaching for this, page 871, if you'll take a look at that. And of course, we're always going to evaluate for therapeutic effects and for those adverse effects. Okay, the levodopa, carbidopa, entacapone. This, you know already how the levodopa, carbidopa works. The entacapone is a reversible selective inhibitor of the catechol-O methyltransferase inhibitor. So it's that COMT. Keeps the levodopa in the system longer to help with the dopamine. The adverse effects of this medication is GI, dermatological, respiratory, and cardiovascular system. For the GI tract, you can be diarrhea, nausea, vomiting, bruxism, dry mouth, and excessive salivation. Now, the development of diarrhea can be a sign of drug-induced colitis, and it will be necessary to stop the medication if that is the case. Also, the risk of melanoma may increase with this drug, and so we got to check out the skin really good. Hypotension is a risk, along with heart attack, stroke, and cardiovascular death. So the contraindications for this is concurrent use of an MAO inhibitor or use within 15 days. And levodopa, again, may trigger that melanoma, so anybody with a history of melanoma should not receive it. The teaching for this, one thing that your book mentions is that the medicine will turn the urine an orange-brown color, and so, but it's harmless, and so we definitely need to teach the patient about that. Also, fall precautions with any of these meds. If they're going to cause orthostatic hypotension or postural hypotension, then we know they're at major risk for falls, so we need to be sure to do that. Evaluation of those adverse effects, we got to be sure to get that baseline of cardiovascular status, and also, check them for chest pain, confusion, weakness of extremities, for CVA, a cardiovascular accident, or a myocardial infarction. Also, be looking at the skin lesions and check about the bowel movements and fecal elimination for that colitis. Okay, now let's talk a minute about anticholinergics as another class of the drugs. And These are used to help control the symptoms and maintain functionability and minimize drug effects and slow disease process. So here we're talking about dealing with the acetylcholine for the anticholinergics. The two drugs listed as atropine and benztropine. Atropine is not used so much for Parkinson's, but we are going to talk about it because it is used in other fashions, but we are going to talk about it here in a minute. Again, the mechanism of action is it decreases the effects of the acetylcholine, and the indications for use is the idiopathic Parkinsonism. It helps decrease salivation, spasticity, and tremors. Now, most of our anticholinergic drugs interact with that muscarinic cholinergic receptors that are in the brain, in our glands that secrete things, in the heart and the smooth muscles. And a lot of times you may see these drugs referred to as antimuscarinic. Atropine depresses the salivary and bronchial secretions and dilates the bronchial tubes and inhibits the vagal influence on the heart and relaxes the GI and GU tract and inhibits gastric acid secretion. In addition, it can help relax the pupils of the eyes and prevents the accommodation of near vision. So you see atropine used with eye exams or anticholinergics used with eye exams to help so we can see in there. The benztropine helps normalize the imbalance of cholinergic and dopaminergic transmission in the brain and helps reduce rigidity, akinesia, and tremors. It also helps suppress the secondary symptoms of Parkinsonism, such as excess salivary secretion and drooling. The indications for these are clients with minimal symptoms and clients who are intolerant with levodopa, or can be used with combination therapy. It relieves symptoms of the extrapyramidal reaction, and it is not effective against the bradykinesia. The development of the central acting anticholinergics has replaced the use of atropine for Parkinson's disease, and impaired renal or hepatic function is contraindicated with atropine. The most common use of atropine is for cardiac rate and arterial pressure during anesthesia when vagal stimulation is affected and we have a decreased heart rate. Atropine also relieves bradycardia and syncope due to hyperactive carotid sinus tone. It also serves as an antidote for cardiac collapse of an overdose of parasympathetic agonist drugs use or cholinergic agents, and for cholinesterase inhibiting agents. Practitioners administer atropine in the pre-anesthesia stage to help reduce respiratory tract secretions, and also atropine is used for mushroom poisoning. Contraindications: glaucoma, myasthenia gravis, GI obstruction, prostatic hypertrophy, urinary bladder obstruction, cardiovascular disorders, hepatic and renal disease, and anybody with cognitive impairment. So remember the old saying about anticholinergics: can't see, can't spit, can't pee, can't S blank IT, or poop if you want to say. Okay, that's the old thing saying with anticholinergics, and those are some of the problems that if a person has them before you give anticholinergic, then we don't want to give it to them. So GI obstruction, prostatic hypertrophy causing they can't pee. So all of those things have to be considered when we're given a anticholinergic. Now, CNS effects of the benztropine, we need to know about that. We can see disorientation, confusion, hallucination, memory loss, psychosis, agitation, euphoria, lightheadedness, depression, giddiness. Peripheral anticholinergic effects can include tachycardia, palpitations, hypotension, orthostatic hypotension, blurred vision, dry mouth, urinary retention, decreased sweating, and an elevated temperature. We got to monitor that eye node. We got to monitor the oral mucosa. If a person's having trouble with urination, then a dosage reduction may be necessary. So we've got to check both eye node, urinary, and also for constipation as well. They can actually get a paralytic ileus with this medication too. So we got to watch for things, intermittent constipation, abdominal pain, diminished bowel sounds, and abdominal distension. It's also necessary to monitor the heart rate for tachycardia with this medicine as well. So we want to teach, always teach, page 881 in your textbook, and then of course evaluate therapeutic uses of therapeutic effectiveness of the medication and those adverse effects. So here's a pictogram of the benztropine, and you can see that it can be given POIM IV, and it speaks to you about different things about this medication, gives you the side effects, and things to watch for. So factors in drug selection. First off, physician's gonna look at the type of Parkinsonism and severity of symptoms, and reduce the levodopa dosages due to levodopa therapy problems, and the optimal dose. We want to start with the lowest dose that allows the client adequate function, and a dosage adjust as the Parkinson's progresses, but it's got to be individualized and gradually increased. Okay, that concludes your podcast.